Okay, so welcome to Eat, Move, Think, the show about optimal wellness brought to you by Medcan.
Wow. Do it again.
Oh, I was practicing. Okay, ready?
Welcome
to Eat, Move, Think,
the show about
optimal
wellness.
brought to you by
Medcan.
Yeah, this is extremely good. Thank you.
Jazz, what do you have for us this week?
Well, this month happens to be Breast Cancer Awareness Month.
It is. Yes,
Yes.
that's true.
Which is particularly important for Medcan.
Because of the milestone that we hit recently. 50% of all the clients at Medcan now are women, which is a big change from where it used to be much more men were clients at Medcan than women. Now it's 50-50.
I love that.
Yeah, it's important because that reflects the fact that more women are becoming executives and professionals. And also more families are joining Medcan as well.
And more women are taking charge of their health.
Yeah, I feel like Breast Cancer Awareness Month is a good time to talk about that and to talk about women's health, menopause, not just breast cancer.
No, women's health in general is not talked about enough, not studied enough, not researched enough. It's just so underdeveloped.
Yeah, friend of the podcast, Dr. Michaela DeVries Abood, has that great study about how only 10% of the studies that appeared in a prominent physiological journal were about exclusively women, which, I mean, that is pretty crazy.
Yeah, our guest on the show today, Dr. Vivien Brown, also mentions that pretty much all of the research done on rats is done on male rats because it's cheaper and it's easier.
But what's the real cost? What are we missing as a result of that? I'm Chris.
I'm Jazz.
We're the producers of Eat, Move, Think. And today, in honor of Breast Cancer Awareness Month, we're exploring women's health with
Dr. Vivien Brown. She is a physician, an author, an internationally recognized leader in women's health. And most recently, she's a Medcan senior medical advisor who's currently helping to build Medcan's very own women's health program from the ground up.
She's in conversation with Bronwen Evans, Medcan's chief growth officer.
If you are like me and most people out there and you don't know enough about women's health, this is absolutely the episode for you. I think this is incredibly important for everybody out there to learn about your own body, about the changes that are going to happen to it, and about ways to cope with it and access information about it.
Let's get to it. Here's Bronwen Evans.
Hi, everyone, and welcome to Eat, Move, Think. I'm Medcan's Chief Growth Officer, Bronwen Evans, and I'm very excited to chat with Dr. Vivien Brown today about women's health overall, and specifically breast cancer and menopause. Dr. Brown is a perfect person to discuss this with. She's an award-winning family physician, speaker, and author who specializes in women's health, healthy aging, and preventive care. She's also hard at work developing the women's health program here at Medcan. Dr. Brown, thank you so much for being here today.
It's my pleasure, Bronwen. Fun to get to know you and fun to be here.
Wonderful. Thank you. So let's start by talking about the landscape of women's health in Canada. How much prominence has this topic had by researchers and the healthcare sector overall? And did that play into your decision to focus on women's health?
You know, that's a very interesting question because I think I'm totally biased. As a female doctor, I see female patients predominantly, and my interest is around how different health issues affect women differently. I think in research, up until really the 60s, 70s, and early 80s, most research was done on men. Even research around hormones was done on men. You know, it's harder to do research on women because of hormonal variations. And even when they do brain research in rats, they do it on male rats because female rats have cycles and the research is more difficult and more expensive to do. But I think we're learning that women are not just 2/3 size of men and that drugs work differently, diseases affect women differently, and women's health is truly an area that I think needs both attention, respect, and research.
Yes, that is interesting. I think, there was an article recently that talked about the impact of the COVID vaccine on women and their menstrual cycles. And the article made the point that really no research had been done on that prior to giving the vaccine. So I think that would be a good example of somewhere where we really do need to think about the impact on men versus women and how hormones figure into that as well.
And, it's interesting you bring up COVID vaccine because COVID vaccine in about 12% of people will cause lymphadenopathy, which is a swollen gland under the arm. Well, why that's so important for women is because when you do a mammogram, if you've got a swollen gland in your underarm, in your axilla, it looks like this could be a risk for breast cancer. So very importantly, don't do a mammogram for 6 to 8 weeks after having a COVID vaccine because it makes the mammogram harder to interpret. So we're learning lots of things and lots of issues that are differentially impacting women compared to men.
Yeah, and you could see how that might cause some unnecessary stress. Would you have to go back for a repeat mammogram? Is that what would happen in that particular case?
You'd have a follow-up 4 to 6 weeks later. Sometimes, depending on what the mammogram looked like, someone may send you for a biopsy. And unless you've got a very astute radiologist or an astute technician that asks the question, have you just had a COVID vaccine? That underarm swelling, that node in the axilla, is considered a cancer till it's proven not to be.
And I know that you've had an opportunity to do an annual health assessment here at Medcan, and mammography is one of those preventive scanning areas that we do. So maybe tell us a little bit about your experience at Medcan and the aspects that you thought were particularly relatable to women's health.
So I'm happy to discuss this, although it's my personal health. And that is in trying to create a women's health program for Medcan, I felt that at the very start, I should know what the basic annual health assessment is all about. And so I underwent an annual health assessment as a patient, and I found it incredibly reassuring. I was actually surprised, given that I'm a physician, given that I think I'm quite expert in a number of areas, just how reassuring the exam was. From the mammogram and ultrasound to the bone density to all the blood work. What I found really special about the program at Medcan was sitting with the doctor at the end of the day, getting all those results in one day. So I didn't have to go home waiting with an abnormal mammogram to find out that, yes, it's all benign and nothing. It was really very, what's the word? I felt taken care of. My life as a physician is taking care of other people. And here was a situation where I felt, and I had a particularly lovely physician, but I felt taken care of by the experience, by the testing, how the results were given to me, and the whole process of looking at my health in a very careful way.
Yes, and obviously the discussion that you have with your physician at the end of your visit who reviews your results, it's a very personalized approach. When it comes to women's health in general, would you say the approach needs to be highly personalized? Should women be getting all of the same tests? Are there some tests that make sense for some that don't make sense for others in terms of therapies? What are your thoughts on that?
Well, I do think women need a slightly different overview than their male contemporary. For example, I think women need a bone assessment at an earlier age because around the time of menopause, with the withdrawal of estrogen, we see rapid bone loss in women. We don't see that in men for another 10, 15, even 20 years. So I think the timing of certain tests is different for women. I think the focus on different areas is different for women. Certainly postpartum and around perimenopause, cycle control, some of those issues are obviously very particular to gynecology and to women's health. So although I think the annual health exam, the way it exists, is a wonderful starting point to then focus on certain areas, depending on the patient, depending on their family history, depending on their risk assessment, it's a time to focus on particular areas.
Okay. And what would be some of those other areas that you think? You mentioned bone health, breast health. What would be some of those other areas, say, for women who are perimenopausal or menopausal?
So clearly breast health is a woman's issue. And I think it's important, and we've talked about this in different arenas. There's a difference between screening and prevention. We do really well at screening. We do mammograms, we do ultrasounds, but we don't necessarily do that well about prevention. And I think women deserve the time and effort to talk about lifestyle prevention, some of the new chemotherapeutic options for prevention. There's nothing that is one size fits all. It really depends on an individual's genetic risk, personal risk, family history. But I think we need to focus on breast health, both screening and prevention. I also think that when we're personalizing our discussions with women, for some women, certain things are very simple. I use pregnancy as the example. Some women don't even know they're pregnant. And then there's somebody like Kate Middleton, the Duchess of Cambridge, who was vomiting and hospitalized early in pregnancy. So hormones affect women differently. Mm-hmm. And I think we need to be sensitive and sensitized to whether someone is going through hormonal imbalance that's giving them great side effects as compared to someone else who may not even be aware of it. We need to personalize the medicine that we do at Medcan, and we need to personalize the overview around hormonal options. Not everybody needs hormones, but for those women that do, it's important to have specialized care so that she can feel much better if she's one of those people that is disabled by the hormonal fluctuations. Mm-hmm. And that's the way I speak to patients. I want to ask the question, not, are you having changes due to menopause? Everybody does eventually.
Yeah.
Are you disabled by those changes? Are those changes affecting your quality of life? Mm-hmm. Those are the kinds of questions that I think need to be answered.
Absolutely. So maybe tell us exactly what is menopause and what the differences are between perimenopause and menopause and how the symptoms change once you go into menopause from perimenopause.
So just so that everyone is on the same page, let's understand that menopause is a transition. It's not a disease. It's a transition where your ovaries stop producing as much estrogen and eventually stop producing estrogen at all. The average age for menopause in North America is between age 51 and 52, but I have patients in their late 50s that are still having periods, and I have patients in their early 40s that stopped having period. So average age is early 50s. We know that we start to go through hormonal fluctuations about 5 to 6 years before that. So if the average age of menopause is 51, a woman of 45, 46 may start missing periods, may have hot flashes and night sweats, may feel unwell for a month or two, and then all of a sudden feel fine again and be back where she started. So hormonal fluctuations is what we call perimenopause.
Okay.
And we don't call it menopause until you've had 12 months of no period. So we only know menopause in retrospect. When I'm sitting here today and I'm talking to a patient, if her last period was a year ago, then she's menopausal. But if she had a period in August, she's not menopausal yet.
Right.
She's perimenopausal.
Right.
And it makes a difference in terms of treatment. It makes a difference in terms of risk assessment. And certainly if you've gone 12 months with absolutely no bleeding, any bleeding after that 12 months can't be just written off as, oh, I had another period. Any bleeding 12 months after no bleeding is by definition abnormal and needs to be investigated. So we always want to double check, probably is hormonal, but we don't want to miss early uterine cancer.
And that seems to be something that not a lot of women would necessarily know about either. They would just assume, oh, I guess I'm not quite done going through menopause. So,
exactly.
So that's something that's really good to know. Speaking of cancer awareness, it's Breast Cancer Awareness Month, and the Ontario Medical Association recently released data suggesting that 400,000 fewer women than expected had mammograms during the pandemic. What do you think the long-term implications of that are? And what would you say to women who have let their screening lapse during the pandemic?
So when we look at screening for cancer, we screen for colon cancer, we screen for breast cancer, and we screen for cervical cancer. So in Ontario, you'll get a letter from Cancer Care Ontario if you're outside of those screening guidelines. If OHIP hasn't registered that you've had a pap test or a mammogram or some kind of colon cancer screening. And when we look at those cancers all together, Ontario is about 1 million tests behind.
Oh, wow.
And what that means is we're going to pick up these diseases later than we should have. Because for some people, by the time they have their pap test or their mammogram or do something for colon cancer screening, whatever early disease was there 3 years ago will have already progressed. So I think it's very important for people to get their screening done at the appropriate time. Certain tests, like a pap test, are every 3 years. Mammograms after age 50 are every 2 years. Colon cancer depends on family history and various other issues. So I think screening is really important. And we have a population that is under-immunized, and we can talk about immunization if there's time, but we have a population that now is under-screened. And these are tests that are paid for by the government. It's cheaper to find something early than to treat it late. And so we should be doing that screening. And I would encourage everybody to check with their family doctor, to check in the mail. Have they received a letter from Cancer Care Ontario and they didn't act on it? This is really important.
So if they've received that letter, or if they know that it's been a significant amount of time since they've had their last mammogram, they should be reaching out to their family doctor to say, I need to get this booked.
Absolutely. And Bronwen, if you're part of the Ontario breast screening program, which a lot of women are in Ontario, you don't even need to speak to your doctor. You can phone the facility that you went to last time, double check that you're at the right facility for where you were before, and book the test yourself.
That's good to know. Yeah. About 75 to 85% of women will experience symptoms of menopause. What can those symptoms be? And what do you think differentiates the 20 to 30% who actually seek treatment?
So typical symptoms of menopause are hot flashes, night sweats, and vaginal dryness. And really what that means is your upper body, your face, your scalp getting very hot unexpectedly. Some women will start to sweat. Some women will turn red. Some women will get palpitations, or they'll feel their heart go quickly. And women can feel very unwell and anxious for a short period of time, maybe just 10 minutes, but it's very disruptive. And, you know, in my practice, I see a lot of women executives. I see a lot of women who are working in high profile positions. And I'll use just the example of a patient of mine who's a lawyer. She's a criminal law lawyer, so she's in court quite a bit. If she gets a hot flash and starts sweating and turning red and having palpitations in the middle of being in court, all of a sudden there's a context that's out of context. It looks like she could be lying, or she's anxious, or something in the court proceeding doesn't seem right because she no longer looks comfortable and in control. So what I ask patients is, are you having hot flashes? 90% of us will have hot flashes at one point or another. I ask, are your hot flashes disabling? Is it affecting your quality of life? Because you may have just 1 or 2 hot flashes a day, but if you're having them when you're being interviewed on TV, or if you're having them in court, that may be unacceptable. So women choose treatment depending on how impactful the symptoms of menopause are.
Right. And you can see how that would really vary from person to person in terms of, to your point, if you're a lawyer and hot flashes, I mean, that can be something that's quite debilitating. But, you know, if you have a job where you primarily work from home, or it may be less so, and you can certainly see that. In your book, which I read, so The New Woman's Guide to Healthy Aging, you mentioned in there some women will even experience hot flashes for the rest of their lives. Is there anything you can do about that? Or
so it's interesting because we now have a medical term, and we call these women super flashers, because they just have hot flashes forever, and there's various treatments that can help. But we don't know why, and we're just starting to learn about some of the brain physiology that affects temperature control as to why some women have so much more debilitating hot flashes than others. I think the issue is very personal. Some women need treatment. Some women will seek treatment, and there's lots of treatments, whether it's hormonal or non-hormonal, whereas other women feel that the symptoms are tolerable and they don't want to be treated. But it's not just hot flashes in menopause. Lots of women get joint pain. They get much stiffer. Women have changes in mood and hormonal instability. So at the time of adolescence, when you first start getting periods, postpartum, when you've just had a baby, and at menopause, these are times of great hormonal instability. And in vulnerable women, it may make depression and anxiety worse. So there's lots of different symptoms at different times. but everybody's experience is different. And I really encourage people, of course, talk to your friends and neighbors. Everybody does that anyway. But everybody's experience is different. And so I do think it's important to consult with your physician at this juncture in life if you're having symptoms that are affecting your life.
It's interesting that there's that link between depression as an adolescent, postpartum depression, and then depression in menopause.
It's a combination of a vulnerability to mood changes and a vulnerability to hormonal changes. And they become additive and affect people differently. So, lots of women have babies and are perfectly fine and perfectly happy. And then we have women with severe postpartum depression where they can't relate to their baby, they can't adjust. And we think that this is hormonal instability. So there's a certain vulnerability, whether it's genetic or not, I don't really know. But that vulnerability we see as a predictor through life.
Okay.
So often someone that has had a hard time postpartum may be the person that has a harder time at menopause.
And is there a link between morning sickness and how you feel during menopause? Is there any evidence of that?
It's a good question, but I don't think there's any particular link.
Well, that's good news for me then.
and even women that have a lot of morning sickness with one pregnancy may not have it with the second.
That's right.
So even in the same woman, same partner, a second pregnancy, she may react very different than a first pregnancy. So that really is unpredictable.
Yeah, well, I think about my network of friends and how they talk about the impact of perimenopause and menopause on their sleep, to the point where some it can be a bit debilitating, like in terms of being able to function the next day and what have you. What are your thoughts around sleep, the importance of sleep hygiene, and how does that rank up there in terms of the kinds of complaints that women experience as they're going through menopause?
Sleep is a huge complaint lifelong. I mean, I think at menopause, it's intensified for some women, but we see younger women with sleep disorders. We see older people with sleep disorders. And I think sleep and stress are very closely linked. And what we know is when you're not getting restorative sleep, and lots of medications will give you a certain amount of sleep, hours where you're sleeping, but it may not be restorative in the way that it needs to be. And we know that if you're not getting restorative sleep, you may not be clearing all the toxins in your brain. You may be at higher risk long-term for dementia. Sleep is really important. I do think sleep hygiene gives us a lot of ideas of what we could do to make our own situation better. I know in my bedroom, I've now turned the clock around so that I can't see the time.
Right.
So I can't keep looking at the clock.
Yeah.
And we know that blue light is really not good for sleep.
Yeah.
And so being in a dark room, being in a cool room, not having your laptop on your belly, lying in bed and then saying, I better go to sleep now and put your laptop away. It's just not going to happen. So I think sleep hygiene is really important. But I also think that there's a number of lifestyle choices that you can make to enhance your sleep. And one of the guidelines says about going to bed at the same time and getting up at the same time, no matter how much sleep you had. Because if you're one of these people that wants to stay in bed longer because you didn't sleep well, it just ruins your sleep for the next night.
Right. Yeah.
And so following these guidelines really does make a difference. And of course, there's some sleep disorders that need to be diagnosed. And so seeing a sleep specialist may be in order. But what we know around menopause is partly it's the hot flashes that disturb your sleep, but partly it's sleep disturbance that may trigger hot flashes.
Okay.
So it's bidirectional. It's both things that are happening. I do find practically when you treat women with significant hot flashes, usually their sleep improves. And one of the things we know is that using progesterone, which is one of the hormones we use for menopause, if you give it at night, it is a little bit sedating just generally as a hormone.
Okay.
And so depending on the time of day that you take your hormones, there may be a benefit for sleep.
Okay, that's a good tip. So, Dr. Brown, let's talk a bit about the program we're developing here at Medcan. We have the annual health assessment, but why do you think it's important to have a women's health program specifically?
So as I mentioned earlier in the podcast, I think the annual health assessment was fabulous. I was very reassured. I felt that the entire day was really well spent. And at the same time, there are a number of areas that are particular to women that I think need attention And there's no time in that busy day of doing all those tests and having your cardiac fitness done and meeting with the dietitian. There's no real time to focus on some issues that may be important to some women. So I don't think all issues are important to everybody, but I think particularly at a place like Medcan, we want to be open to be supportive to women in areas that may not get the kind of attention that they deserve for some women. And so I'll use the example of brain health. 70% of new Alzheimer's cases are in women.
Wow.
Women are most likely going to be the caregivers of people who do have dementia. And we know that very little research has been done on women's brain health. Now, full disclosure, I sit on the board of the Women's Brain Health Initiative as the medical advisor. And this is a group that's working really hard for the last 10 years to increase funding for women's brain health and research in women's brain health, because the drugs work differently, the tests are different, women score differently on testing, and women deservedly should be worried about dementia since women are more likely to have that diagnosis. So one of the things we're developing at Medcan is a 2-hour module to evaluate brain health in an individual person. That will include a discussion of the MIND diet, which is the diet that's been associated with a decreased risk of Alzheimer's, the appropriate exercise for brain health, a discussion on the pillars that affect your brain. And there's 6 main pillars, including exercise, sleep, stress, some of the things, Bronwen, that we've talked about. But looking at those pillars for an individual person, and then looking at how to help someone make some lifestyle changes to prevent dementia in the future. I think that's an important area that is not looked at in detail in an annual health exam. And I think it's important that women who perhaps have a family history, perhaps are more worried for whatever reason, perhaps have noticed some changes in their own cognition, their own memory, their ability to concentrate. If they've noticed those changes and they want that deeper dive into their own brain health, I think that that's one thing that we should be supportive and offer that evaluation. So again, it's not necessarily for everybody, but I think it's an important area to look at.
Okay. And another area that you explore in your book is hormone therapy. How do you see hormone therapy fitting into a program on women's health at Medcan?
So that's a separate module that we are creating in terms of helping an individual woman decide, are the symptoms she's having menopausal? Are they anxiety? Are they thyroid related? Are they normal for her, but maybe not normal overall? So let's decide if she is experiencing significant menopausal symptoms. And then if she is, there's some great medications, both hormonal and non-hormonal, for her to consider. I think I mentioned earlier that about 80 to 90% of women will experience hot flashes. About 20 to 30% will want treatment for hot flashes. So if someone is in that 20 to 30%, we need to let her know what the pros and cons are for taking hormonal therapy. And there's a difference between oral therapy, transdermal therapy, or local estrogen therapy, which is basically vaginal therapy. So I think we need to have the time to educate someone so she knows what her options are. And she then may choose to be treated or she may choose not to be treated, which is fine as well. But I think it's important that we offer that level of education and that level of assessment in someone that's having significant menopausal symptoms.
And at what point should you be speaking to your doctor about hormonal therapy? And does it make any sense to get your hormone levels tested?
Great question. I think women should talk about this early in their 40s. You know, I mentioned to you that you go through perimenopause approximately 5 years before your final period. Women may be having cycle changes in their early 40s, 45, 46. It's important to bring up the issue, get an idea if this is what's happening to you. Having said that, having that education is always a good thing. It doesn't necessarily mean you're choosing treatment at age 45 or 46. But the bottom line is we have options, and I think it's important for women to understand what those options are and to decide whether or not they want to be treated or whether they're coping in some other way.
Yeah. And if you think about other aspects of the women's health program at Medcan, we've talked about brain health, we've talked about hormonal therapy, breast health. What other areas do you foresee? I know it's still in development, but what other areas do you foresee being part of the women's health program here?
Well, we're talking a lot about pelvic floor health and sexual health. Pelvic floor really is an area that sometimes gets damaged in pregnancy, so it's not necessarily just an issue for older women. It can be an issue for younger women, and that has to do with the ability to be continent, to not have leakage. So women that have urgency or stress incontinence or are leaking when they cough and sneeze sometimes have a pelvic floor issue. We also know that somewhere around 10% of women have sexual dysfunction and want the opportunity to talk about their sexual life, good, bad, or indifferent. And so we're creating a module that's looking at pelvic floor function and sexual function for women that are interested in this area and that want some coaching about what they can do, how they can do it, and how they can improve their situation.
I would think one of the interesting things in having specific modules is that you're laying out for women what they can ask about or should be asking about, because it might not occur to a woman who's seeking help around menopause to talk about, their sex drive or bladder leakage or what have you. It's one of those things where you just think that's something separate and what have you. But I would imagine that as having it part of a module and just putting it out there, that would give women confidence and comfort to come forward to talk about that.
You're absolutely right. And the research shows that when we give women the opportunity to be in a safe, private environment, the majority of women want to talk to their healthcare provider. They want to talk about their relationship. They want to talk about sexual function. And often if the doctor doesn't ask the question, the woman walks out and says, well, it can't be important. They didn't even ask me about it.
Right.
And so what we're doing in creating these modules is we're opening the door to talk about whatever is important in your health, in your family history, for your age, for your relationship, for your situation.
Yeah, I think that that's a really important approach. And I think to the point that you made earlier, it's really about figuring out those aspects, those symptoms that are preventing you from flourishing, preventing you from achieving what you want to achieve, whether it's professionally, personally, and really making a program that's personalized to every woman who comes through. So there is some time before we formally launch the women's health program at Medcan. So in the meantime, in addition to breast cancer screening, if you haven't had it, if our clients are seeking support, what would you tell them?
I think step one is to come and have your annual health assessment. Let's see what the baseline is. Let's see if you're at risk for cardiac disease. What's your bone health? Let's see where you are right now. It's like a snapshot in time. Let's get an idea of where we're starting from. And then by all means, speak to the doctor that you're seeing about what your concerns are. The modules we're creating are on breast health, bone health, brain health, menopause and hormone health, and pelvic floor and sexual function. You don't have to wait for the modules to be ready. You can come and talk to your doctor now if you have an area that you're concerned with. And whether you do that on the day of your annual health exam or whether you decide to book back to have a more in-depth conversation, this is all about personalized medicine. This is all about you. And we can only do the best we can when you share with us what your main concern is. And so I would encourage people not to be shy. Everything's confidential. Most of the time, the doctor is comfortable in the areas you're asking about. And if they're not, we have enough staff and enough background and enough depth of experience at Medcan to send you to the right person.
It's great. And then, of course, there's your book, which I read through in the last week. And given that I'm in the perimenopausal stage of my life, I found it quite interesting to go through. So in your book, you highlight many of the things that we talked about. Is there anything that we've missed that you'd like to focus on in terms of what you recommend in your book, or any sort of specific healthcare advice that you would have for women?
I couldn't be true to myself if I didn't talk about how important it is to be properly immunized. We take for granted what's available in Canada, and we often don't get ourselves properly immunized, whether we're talking about flu vaccine at this time of year, pneumonia vaccine, shingles vaccine, depending on your situation, HPV vaccine to reduce your risk of cancers. It's really important to speak to your physician and be sure your immunization is up to date. We've learned a major lesson with COVID. First couple of months with COVID, we were at ICUs overflowing with people on ventilators. We're not hearing that much anymore. We've immunized the bulk of the population, and so even when people are getting an infection, they're not necessarily dying of that infection. That's the power of immunization. And so when we're looking at preventative health and we want to prevent these cancers and brain disease and bone disease, let's also prevent pneumonia. Let's also prevent influenza. Let's also prevent shingles, which, although not a killer disease, is such a debilitating disease to the people that have it. And, Bronwen, 50% of Canadians will have shingles by the time they're 80 if they're not immunized. This is very common in the general population. So, yes, I think it's important to think about preventions, and part of the preventions are preventing the vaccine-preventable diseases.
And I would think with immunization, it's an area where you have to be proactive on your own, and you shouldn't assume that your physician necessarily will mention the vaccines to you. So that's a really good point.
Well, thanks for asking the question. I think really when we think about preventative health, let's think about the whole person, and that includes preventing these diseases.
Dr. Brown, this has been a great discussion. I've really enjoyed chatting with you about this today, and I feel confident that you've just answered a lot of questions for a lot of our female listeners, and perhaps even encouraged them to get breast cancer screening or to make some lifestyle changes, or even reach out to their doctors to have a conversation. Thank you so much for being here. Stay well, everyone.
Thank you, Bronwen. It's been a pleasure.
That was Bronwen Evans, Medcan's Chief Growth Officer, in conversation with Dr. Vivien Brown, MD, author, and Senior Medical Advisor to Medcan.
Follow Dr. Brown on Twitter at Dr. Vivien Brown. That's DrVivien Brown. And follow Medcan on Twitter and Instagram at MedcanLiveWell.
We'll post episode highlights and links you can visit on our website, eatmovethinkpodcast.com.
Say hello and send us a tip or a suggestion by emailing us at info@eatmovethinkpodcast.com.
Eat Move Think is produced by Ghost Bureau. Jasmine Ratch is managing producer. Social media strategy support is from Chantal Gertin, Andrew Imex, and Emily Bozick. Executive producer is me, Christopher Shulgin.
We'll be back soon with a new episode examining the latest in health and wellness.
This podcast is intended to provide general information about health and wellness only, and is not designed or intended to constitute or be used as a substitute for medical advice, treatment, or diagnosis. You should always talk to your Medcan healthcare provider for individual medical advice, diagnosis, and treatment, including your specific health and wellness needs. This podcast is based on the information available at the time of preparation and is only accurate and current as of that date. Source information and recommendations are subject to change based on scientific evidence as it evolves over time. Medcan is not responsible for future changes or updates to the information and recommendations and assumes no obligation to update based on future developments. Reference to or mention of specific treatments or therapies does not constitute or imply a recommendation or endorsement. The links provided within the associated document are to assist the reader with the specific information highlighted. Any third-party links are not endorsed by Medcan.